Okay, so I'm Taylor, obviously, for those who can't see me on the Zoom screen. But I have the pleasure of introducing my father, who actually is an intensivist. He also works as a neurophysician, has been since he's finished in the 70s and 80s of medical school down in Louisiana. So he is currently the ECLS, or Extracorporeal Life Support Director, and he was actually really kind of the founder of that program since the early 90s, and has been working at that institution and has been a part of the kind of forefront of research into extracorporeal life support, as well as working with ELSO, even in the past few years, to kind of educate, teach, and expand that program kind of throughout the world. And so I have the honor of letting him talk. He's going to talk about ECPR, which is probably something that we might end up seeing a little bit in the future. So.
How is my voice coming through on the? Well, good. Well, it's a pleasure to be here. I have to come all the way to New York just to meet with Taylor, because he doesn't come home anymore. But it is a distinct pleasure to come up and be able to address you about something that's near and dear to my heart, and has been for almost 30 years. What I want to present today is an overview of ECPR, Extracorporeal Cardiopulmonary Resuscitation. Probably should start with a formal definition. And this is a definition which comes from a nomenclature paper that describes the abbreviations, nomenclature, and descriptions of all aspects of extracorporeal support. And ECPR is defined as the application of rapid deployment. Obviously, if you're in a cardiac arrest situation, you have to be able to deploy your support rapidly. Veno-arterial, I'll explain later, but that's the mode of ECLS that's necessary to support patients in cardiac arrest. Usually by peripheral cannulation, means you're not cracking the chest in the emergency department. You're putting things in through a peripheral artery and vein to provide circulatory support in patients in whom conventional CPR is unsuccessful in achieving ROSC. And everyone's definition of ROSC is a little different. So this definition is in alignment with definitions from the American Heart Association, and that ROSC is deemed to have occurred when chest compressions are not required for at least 20 minutes and signs of circulation continue to persist. So we're looking at patients who are still in cardiac arrest, not post-arrest cardiogenic shock. That's considered a different mode of support, but actually to help achieve ROSC. So it implies the application of ECLS during conventional CPR, which can be challenging. And the use of ECLS, as I just indicated, for cardiogenic shock following ROSC is considered veno-arterial support for cardiac failure. So we're only targeting, in terms of ECPR, patients who are in active cardiac arrest not responding to conventional therapy. I'll give you an overview of all the different types of extracorporeal therapies and where ECPR fits in. The family of therapies that involve extracorporeal support, we term ECLS, or extracorporeal life support. And we break this down into two broad categories: ECMO, or extracorporeal membrane oxygenation, and ECOR, or extracorporeal carbon dioxide removal. ECOR I'm not going to address today. It is a low flow level of support that is used primarily to provide removal of carbon dioxide. The amount of blood flow is too low to support oxygenation, and it's primarily used in hypercapnic states and in lung protection during mechanical ventilation. On the ECMO side, we can apply ECMO in three different modes of support. Veno-arterial. Veno-arterial, and I'm going to jump to the next slide quickly, means that we are drawing blood from the venous system. This is typically going to be the IVC, the right atrium, or the SVC. Through a blood pump, through a membrane lung or artificial lung, which provides a gas exchange, and then back to the patient. If this return cannula goes back to the arterial side, hence veno-arterial, so we're draining from the venous, returning to the arterial, we call that VA, and it is used primarily for cardiac failure. It does provide gas exchange as well as cardiac support. However, in patients whose heart is actually beating, it will not supply the upper body with oxygenated blood. But in the cardiac arrest patient, it will supply both the cardiac support as well as full gas exchange support. So VA ECMO is what we're going to target, and I'll talk today, and it can be used for cardiac support, for ECPR, or for organ donation following donation after cardiac death, or extracorporeal interval support for organ recovery is what ISOR stands for. If we have just pure respiratory failure, such as our patients with ARDS, we'll use veno-venous. So we're returning the blood back to the venous side. We might withdraw from the inferior vena cava and return back to the superior vena cava, but it does not bypass the heart and lungs, does not go to the arterial system, and therefore does not support cardiac function. It supports just gas exchange. And if we have a patient with combined cardiac failure who's not in cardiac arrest, cardiac and respiratory failure, and then we can supply both a combined veno-venous and veno-arterial to provide the upper body oxygenation as well as the cardiac support. We're going to focus on VA ECMO for ECPR. Going over this slide, the gas exchange device, the artificial membrane lung, functions just like your lung. It has a blood phase corresponding to your capillaries. It has a gas phase corresponding to your alveolar ventilation, which is run by just flowing oxygen past the membrane. And these two phases are separated by a membrane that allows gas exchange to take place by diffusion, but does not allow blood to get into the gas phase or gas to get into the blood phase. And it works analogously to the lung. If we want to transport more oxygen, we just increase the blood flow, just as you would increase your cardiac output. If we want to change our removal of carbon dioxide, we can change the gas flow through this device, which is comparable to changing your minute ventilation. So if you hyperventilate, you'll drop your PCO2. So the same physiology applies here. The cannulation configuration for veno-arterial is most commonly performed through the femoral vessels. So if you're doing an ECPR, this is out of the way. The other alternatives are primarily surgical, to open the chest, cannulate the aorta and the right atrium directly. But again, that's not frequently done in the ED setting. So these cannulas are placed through the femoral vessel. There is a drainage cannula, shown here in blue, which is inserted into the IVC all the way up to the diaphragm. Blood is drained from that cannula through the system and returned into the femoral artery, wherein the cannula lies either in the iliac or in the distal aorta. And then blood flows retrograde up the aorta to provide blood supply to the rest of the body. If the patient is in cardiac arrest, this blood will flow all the way up to the aortic valve, and it will supply blood to all parts of the body, brain and heart included. But in the patient who has some cardiac activity and is ejecting blood, then that blood will not get that high up. But since we're dealing with patients in cardiac arrest, you can expect this circuit to fully oxygenate the body with normal saturations as well as normal carbon dioxide removal. So what's been changing? we're seeing an increasing adoption of ECPR around the world. The Koreans, the number of other patient groups, countries around the world are widely adopting this much more than the US. And so we're seeing this now as the most rapidly growing aspect of extracorporeal support in patient care. Also, we recognize this has to be a component of a system-based care. The system has to start with EMS and end up all the way through the cath lab into the ICU. This is not purely an ED procedure. It's an ED procedure in the context of an entire system that can identify the right patient, put them on support, get them to the cath lab for revascularization, and then to the intensive care unit. We also recognize the types of patients we have to target, and we're seeing a shift towards emergency physician use and not strictly the domain of surgeons. The reason that ECPR is gaining ground is because the alternatives are pretty dismal. This is just a study published in 2015 of cardiac arrest treated by just basic versus advanced life support. You can see the outcomes are pretty dismal. This is out of hospital, survival to hospital discharge on the order of less than 15%. And in most and survival to 90 days, half of that. And interestingly here, survival with basic life support is higher than survival with advanced life support. The reasons for that remain to be determined, but it could be just patient selection. There is some trend in improvement after in-hospital cardiac arrest, but still pretty dismal. The overall in-hospital arrest statistics are not much better. However, those patients who developed VFib or VTAC as a presenting rhythm had a much higher chance of surviving an in-hospital cardiac arrest, and those with asystole and PEA much lower, presumably because these rhythms develop as a result of comorbidities and underlying disease from which recovery is not likely to be good anyway. This group of patients tends to target those who have a sudden acute ischemic event producing this dysrhythmia, which has a higher level of survival, especially with revascularization. This is just an example to show you, and this is just through 2017, the rapid rise in ECPR growth in adults. It's been used quite a bit for children for in-hospital use, but it's only been in the last few years that we've seen this increase for adult out of hospital and in-hospital cardiac arrest. This data is international, so this includes not only the United States, but a number of other countries around the world, which are actually leading the charge in the application of this technique. Survival is still not great. This is just a registry where cases are entered. It's a voluntary registry. And in patients who underwent ECPR with VA support, we're looking at about a 30% survival. That is overall, that's inpatient, that is outpatient or out of hospital. That includes all types of rhythms and so forth, and is not necessarily a reflection of what could be done. And in fact, what can be done, I'll show you some data on, could be much better. Some of the earliest reports of single center experiences, this was published, this is a group, I think from the Czech Republic, 30 patients with out of hospital cardiac arrest. Pre-hospital CPR, less than 100 minutes, which is a pretty extensive period of time, but an end-tidal CO2 greater than 10 on arrival to the hospital, indicating that these patients were having an adequate CPR. And they had to have a no-flow time of less than 5 minutes. In other words, bystander CPR had to be started pretty much at the time of the cardiac arrest. So if patients had a long downtime, they were excluded. And this was not a randomized trial. This is just a single center experience. So these were the inclusion time. The actual mean CPR time ended up being 96 minutes before they got on extracorporeal support. And this is what I'm referring to when I meant system care. These patients were routed directly to the cardiac catheterization lab for intervention. Once they were either put on ECMO in the ED or in the cardiac cath lab, and they underwent intervention, but they did not describe exactly what they did. And they had a 46% survival with favorable neurologic outcome. Single center, non-randomized, but still, this is extremely good data or suggestive that there's something to this. There was nothing that discriminated in this group between survival and non-survival. But it did note that there were some variation in survival related to duration of CPR and presenting metabolic disorder and CO2. So choosing the right patient is going to apparently be key. Here's another European study, 34 patients with acute MI in hospital arrest. So now we've switched from the out of hospital to the inpatient. Diagnosed with, these were post-acute MI patients who were arrested after having their MI. They could have arrested anywhere, cath lab, ER, ICU, operating room, hospital ward. They underwent CPR for 74 minutes, did not respond before ECLS was implemented. And all patients underwent coronary angiography, and of those, reperfusion was required in 30. And they had 70% of these patients survive. Again, probably a little more control over your patient selection. You know exactly when these patients had an arrest, you know exactly what their no flow time and so forth. So the only predictor of survival in this group by multivariate analysis was the shorter you could get them on ECLS, the higher survival. And that's not unexpected. This is the first more extensive evaluation. This was a non-randomized trial to determine proof of concept and get some initial data. The Minnesota Resuscitation Consortium set up a system-wide protocol for identifying out-of-hospital cardiac arrest. EMS was part of this protocol. They would go to the scene. They would identify if the presenting rhythm was VFib or VTAC. They would identify patients within that age group. They also required a downtime of less than 5 minutes. They had to be refractory to 3 attempts at defibrillation. They received amiodarone. And they had to be able to accommodate a Lucas device. The bihabitants had to be able to allow that because every patient was on a Lucas for consistent CPR. And they had to have a transfer time to the cath lab of less than 30 minutes. Various exclusions, such as nursing home residents, DNR, do not intubate, and so forth. But this shows the progression of the selection of patients. But let me jump to the next slide, which shows that there were 27 patients transported, 9 excluded because they didn't meet all of the inclusion criteria. 18 patients were transported. These patients, of course, were in the cath lab and the ED were notified by EMS so that these patients went straight to the cath lab. They bypassed the ER, went to the cath lab, and were examined and evaluated in the cath lab. And if they were still in arrest, they underwent placement on ECLS at that time. And then they underwent diagnostic angiography and revascularization if indicated. And they reported a survival with good outcome of 50% that persisted to 30 days. So again, this not a randomized trial, but just a single center experience, but still showing that this is really feasible to do. And as a result of this increase in utilization and some single center experiences. The American Heart, in its 2019 update, indicated there's insufficient evidence to recommend the routine use. We clearly don't have enough data, but it may be considered when all other efforts fail. So they're not saying don't do this. They're saying this is something you can consider if it's something that you can provide. Not a very high level of evidence, but still there was sufficient evidence to provide that recommendation. But this is a study that I want to focus on a little bit more. This is the same group, the Minnesota group, who then conducted a randomized trial. Again, not a large number of patients. So they enrolled patients 18 to 75, the same criteria that they used for their non-randomized trial or study. Out of hospital arrest with a shockable rhythm, no ROSC after 3 shocks, placement on a Lucas, and transport time 30 minutes or less. They randomized 36 patients, of which 6 were ineligible based on exclusion criteria. 30 met all the inclusion criteria and randomized half and half to early ECMO facilitated resuscitation or continue with ACLS. One patient refused to continue to participate, so there were 14 in the ECMO group and 15 in the ACLS group. Here is the survival curve. This is the ECMO group. This is the non-ECMO group. A pretty stark difference, very high, a very significant p-value. And here's the important data, that these patients who survived and were discharged had reasonably low CPC scores and other scores of functionality. So these were reasonably functional people. These were not vegetative patients who were destined to live an extended period of time following this treatment without any hope of meaningful recovery. So this is something to pay attention to. I mean, again, small, just 30 patients, but even with that smaller group, the ability to determine that there may be a potential benefit to this technique. So again, if you were to select ECPR, the consensus for most groups that are doing it is it has to be witnessed. Okay? That excludes a lot of patients because they come in unidentified. No known comorbidities. Often you don't even know your comorbidities when they come in cardiac arrest. Immediate initiation of bystander CPR to limit the amount of no flow. Good quality CPR, which is sometimes hard to determine, and then an end tidal greater than 10, showing that that was indeed a good quality CPR. A shockable rhythm, and no sustained ROSC, and ability to achieve support within 60 minutes. So this is only a fraction of all of the patients presenting to your ED, but it still may be a target population that we can do something about. So let me delve a little more into the techniques and how we get these patients cannulated and placed on ECLS. Ultrasound plays a big role. This ultrasound has really transformed cannulation for ECMO. Prior to about 20 years ago, all ECMO was performed by surgical cut down. So if you wanted to do ECPR in the ED, I'd have a surgeon there, cut down on the vessels and directly cannulate the femoral artery and the femoral vein. But we've transitioned now to percutaneous cannulation, and that transition has moved the realm of cannulation away from surgeons, and not away from, but to outside of surgeons, to also include ED physicians, intensivists, cardiologists, interventional radiologists, all have the capability to now cannulate patients. And ultrasound is what has helped to make cannulation much safer when you're going percutaneously. If you're doing a surgical cut down, you can see the size of the vessel, and you can put in a cannula that's large enough to support your flow, but not too large to cause injury to the vessel. But when you're going blind and you're trying to put in a large cannula and using multiple dilators, and the risk of injury can be significant. So ultrasound has allowed us to identify that we have a vessel large enough to get our cannula in, help us to select the proper size cannula, to evaluate for any vascular anomalies that we weren't expecting, and they do occur. It also helps us to identify where we should access the vessel. Some patients have a femoral artery that may be sitting on top of the femoral vein instead of next to it. In fact, about 25% of patients have variation from the normal anatomy. And this allows us to identify how to get to the vessel of choice without injuring the remaining vessel. And it helps to assure midline vessel entry. Because if you're putting in a 16 French cannula into an artery that might only be 20 or 21 French, if you don't get it exactly dead center going in, you have the risk of injuring that vessel. It also allows us to assess whether after we get the cannula in, if we have sufficient flow to the rest of the limb, since these are large cannulas that can obstruct most, if not all, of the flow. And identify whether we need to put in another cannula to perfuse the distal limb. So where do we go in? Arterial cannulation is in the common femoral artery. Now, in the heat of the moment and without ultrasound, you may often go a little more distal, and you may not actually hitting the common femoral. You may be hitting the superficial femoral, which is a little smaller, not able to accommodate as large a vessel. So ultrasound can identify where the superficial and the deep femoral arteries come off the common femoral, so we'll identify that junction and allow you to safely go above it and get your cannula in. If you do have to put in a distal cannula to perfuse further down the limb, we put that, a smaller cannula, into the superficial femoral, and that can be identified also by ultrasound. Venous cannulation, similarly, we want to get above the greater saphenous vein takeoff, which is shown right here, and get above that to have the largest vessel available for cannulation. And ultrasound allows us to easily measure the size of that vessel. If your vessel is relatively circular, like the femoral artery, and usually the vein, then we just have to measure the diameter. We get the French size by multiplying the diameter in millimeters times 3. If you have a 10 millimeter or 1 centimeter artery, that's a 30 French vessel. Likewise, you can use the ultrasound to measure the circumference. Takes a little bit longer, but maybe if you're not in such a hurry and you have a vessel that's not circular, then the circumference in millimeters is actually equal to the French size. So that will tell you if you have to make sure that vessel is large enough to get your cannula in. And in order to support enough flow, you have to have a large enough cannula. If the cannula is too small, you're not going to be able to achieve an adequate support. And typically it takes a 16, 17, or 19 French cannula in order to get adequate flow of 4 to 5 liters per minute. A semipercutaneous cannulation can be done by incising the skin and identifying the vessel directly, but rather than accessing the vessel with an arteriotomy or venotomy, you can do a guided, visually guided percutaneous cannulation, which causes less complications down the road. This is in the realm of having a surgeon available with you. Another approach that ED physicians have taken, especially when starting out in an ECPR program, is staged cannulation. So and this is the way a lot of groups have started, if the ED physician has not yet been trained to cannulate, they can save time for the cannulating surgeon by using ultrasound, identifying the vessels, and putting in smaller cannulas, such as a sheath, as shown here, into the vessel and have it ready to go. And then when the surgeon arrives, all he or she has to do is guide wire exchange and put in the cannulas. And that's called a two-stage cannulation, with stage 1 being performed by the ED physician and stage 2 being performed by the surgeon. But many programs have just migrated to the ED physician doing the full cannulation. So ECPR, I think I can argue that it's rapidly becoming a domain of the ED physician, and not just the surgeon or the cardiologist. And there's precedent for that. All the way back in 1998, Manny Rivers and his group published their experience in being able to get patients on and cannulated in the emergency department by ED physicians. And they were very successful in getting patients on, but they weren't so successful in getting them out of the hospital. But this is really a feasibility study as to whether emergency physicians can do that cannulation in the emergency department. That's all the way back in '98. The group that sort of moved things forward quite a bit was the ED group, Joe Belezio and Zach Shiner out of San Diego, who started their program with Walter Dembinski, who is a cardiac surgeon. And they saw the potential benefit of ECPR, so they started a program in their ED in which they did stage 1 cannulations, and then Dembinski, who's usually in the hospital, would come down and complete the cannulation. But they have subsequently moved to this group doing the cannulations themselves. And so why emergency physicians? And why would they play an important role in any ECPR program, even if it's outside of the hospital? Well, you guys are resuscitationists. You're the experts at resuscitating patients. You manage out-of-hospital cardiac arrest. And if you're working in a small community hospital, you might be managing the in-hospital cardiac arrest as well. We also have evidence that non-surgeons are very effective at cannulating. This was our experience, not just in ECPR, but in all cannulations, where we identified our experience with 200 percutaneous cannulations by non-surgeons, and we only had 2 patients with complications out of that 200, which is probably less than what's seen with surgical cannulation and other approaches as well. So it's feasible for non-surgeons to cannulate. And you're in the right place. ED physicians are always in the hospital. Most hospitals don't have ECMO teams around the clock. So if you have to put someone in ECMO, they have to come in from outside, but the ED physician is always there. It may not be economically feasible for non-ED physicians to come in for non-high volume centers. And then cardiac arrest patients present to all size hospitals, not just those with 24-hour availability of in-house ECLS. And so therefore, ED physicians are readily available for rapid deployment ECLS. And not only ECPR, but perhaps even for the patient who presents in cardiogenic shock in the ED. It's the same technique that you would be applying in ECPR. And in fact, we could consider ED ECMO as being able to support both of these groups of patients. So it's the potential for ED physicians that they can offer ECPR to everyone in the hospital, both coming in through the ED as well as inpatient, assuming that ECPR becomes more widely accepted and maybe something that ED physicians get in down the road. It's practical and economic to have them available. They're ED-based. And if there's no in-hospital team present, they may be able to support in-hospital cannulation. And that way, these patients can get on ECMO. The ED physician would do the cannulation, get them on ECMO, and then the ECLS team would arrive and continue the care of the patient. So it's possible that rapid deployment ECLS for the ED physician may also include some degree of inpatient ECMO as well. So the roles of the ED physician, one, they can just call the team. So if you're not cannulating, you call the team with a system set up for ECPR. As I mentioned, the next stage might be to perform first stage cannulation with ultrasound guidance and smaller cannulas, or migrating on towards performing ECLS cannulation in the ED directly. This does require collaboration with other services. Surgeons are absolutely needed if you have a failed percutaneous cannulation. So we don't operate to the exclusion of our surgeons. They are part of our team, but we bring them in when needed. So if we have vascular complications or we're unable to complete a percutaneous, that's where the surgical team plays a significant role. And we have to collaborate closely with our intensivists, because if we cannulate and put on ECMO in the ED, we have to transfer that care to the ICU. And perfusionists who may assist with technical issues. Perfusionists play various roles in different ECLS programs. In our program, they don't play any role whatsoever unless we just need some help. We are completely self-sufficient. Other programs use perfusionists for all ECLS cases. So that varies quite a bit. I think in the US, you'll see primarily, maybe in 20% of centers will have perfusionists doing the primary ECMO delivery. And most of the rest of the programs, most of the rest of that 80% will have perfusionists available for resource support, backup, education, and so forth, but they may not play a direct role. And of course, you have to have institutional support. Otherwise, you're not going to be able to get off the ground. So in conclusion, I think ECPR is feasible. And it is an advanced support modality that may offer a way of supporting patients with refractory cardiac arrest that may improve their survival. We're now in a rapid adoption phase. We probably are adopting more rapidly than we have data to support, but that is providing us with a significant amount of experience that may help guide us in future trials. This statement actually should be changed because we have at least one prospective randomized trial, albeit it's very, very small. And that trial, I think, its most important aspect is that it's feasible to do these kinds of trials, and it's feasible to do ECPR and potentially improve survival. It is a multi-specialty approach. It needs to be incorporated into a system for patient management, all the way from EMS through the ED and cath lab to the ICU. Or if you're inpatient, the START team, cath lab, and ICU. And then again, continue studies to identify which subpopulations may be needed. Okay, and with that, I'll conclude. I kept it short, and I'll be glad to answer any questions.
When you have the image that broke down ECMO versus CO2 removal, there's VA ECMO for cardiac arrest, the ECMO for respiratory arrest, then there was a PDA option. Exactly. Just for the, I'm just curious, when you get cardiac failure, that's what I could replace two veins catheters.
Right. Let me, if I can just bring up another presentation. You want to bring, I have another presentation that shows it. So let me just bring that up. Get past all the junky lung stuff here and get to the meat. Okay. Slide there. Okay. So this is VV. We'll just talk a little bit more about the cannulation strategies for all types of support. Veno-venous, we traditionally do by one of two approaches. One, we have single lumen cannulas. The drainage cannula typically here is on the order of 24 to 28 French. We insert that through the femoral, we guide it up to just below the diaphragm. And the reason we want it that high is because compression of the abdomen on the inferior vena cava causes collapse of the IVC, and it may impair drainage. If we get it up to where the liver tends to stent open the IVC, because the IVC really is just a conduit right through the liver. And so it reduces our drainage problems. And then we return it through the IJ into the superior vena cava. The alternative for veno-venous is a dual lumen cannula, which drains, let's see, I think right here, and this little inset. It's a single lumen cannula that drains from two spots, the IVC and the SVC. And the second lumen reinfuses directly towards the tricuspid valve. So this allows one cannula to go in, allows patients to be more mobile when they're recovering. And it saves time by being a single site cannulation. In VA, I showed you, we typically we'll drain from the IVC, but we can also drain from the SVC. Typically, if you're doing CPR, though, you're going to want to go femoral because it's just difficult. You're going to have to interrupt CPR to try to get into the neck. But you can drain from either way. So a lot of non-ECPR cardiac support will have the drainage cannula placed in the IJ and the return placed in the femoral. The carotid is another option, but the stroke rate in adults is high enough that people tend to avoid it, but it is a possibility as a last resort. And in neonates, it's that for VA support, it's actually the preferred approach. But, and then you wanted to talk about VVA. So that's just a combination. What we do is we drain from the inferior vena cava through the circuit, and then we split the circuit. So we direct blood to the superior vena cava for the VV component, and we direct it to the femoral artery for the VA component. And we can, using clamps, we can adjust how much flow goes to each limb. That way, if they need more cardiac support initially, we can direct blood there. We can actually get much better flows through this system than through a single lumen because we have now two cannulas that afford less resistance for flow so that we can get adequate both cardiac and pulmonary support. And if the patient recovers the cardiac function before respiratory, then we can wean that off and continue on the VV or vice versa. So, and it can all be done percutaneously, and it's highly effective at targeting your care to what type of organ support is needed.
Does the use of vasoconstrictors make it more difficult for the catheter?
It does not appear to be. That's a good question. We don't know. But on the good side, if you can get it in a vasoconstricted artery, you don't have to, you're going to be coming off your vasopressors because once you get on support, you have enough flow, you can generally relax your vasopressor requirements. But I think the effect of the vasopressor is going to be a lot more on the smaller vessels than on the larger vessels that we're cannulating here.
Are you guys doing the method where when someone comes to cardiac arrest, they're going to the cath lab and getting the VA set up, or are they
Well, we have not formalized our ECPR program yet. We've done it on when all the stars were aligned and everyone was in the right place, but we did not have a formal program for it. But we're now moving in that direction. COVID kind of set us back a little bit. It also delayed our acquisition of some new equipment. But now that we have the newer equipment that's more portable, we have already trained our ED physicians in cannulation and put them through the ECMO training course. We are also expanding our cath lab capabilities. So we are lining up to kick off, and I suspect probably by the end of this year, we'll be able to formally have a program. We've already got the buy-in from EMS, cardiology, so everything is lined up. It's just kind of COVID distracted us from getting things done. Plus for months, we had a shortage of interventional cardiologists where we could only offer interventional support maybe 75% of the time, and you can't offer a program if you're not going to be able to do it consistently.
First of all, thank you for giving the lecture.
Okay.
I just have a question operationally. When we continue to get more and more evidence for this working, where do you see this going? Is this something that we should be offering in every hospital, or is it more kind of having centers, EMS, identified patients and bring them there, kind of like stroke centers and CAT centers? It seems like it would be valuable for all patients.
My opinion is that there should be centers set up for doing it, because it's not just putting them on in the ED, it's taking care of them afterward. The way I think a system would be set up with smaller, more outlying hospitals might be a star-based approach, where smaller hospitals could be trained to put them on, but then a larger center that you have an agreement with would come pick them up and continue their care. And especially if there's no interventional support at that hospital, then they would be transported. But being transported on ECMO as opposed to manual CPR or Lucas device is different, because you're able to support all the organ function, and that buys you a lot of time.
There's a question on Zoom, Robbie, go ahead.
Hey, can you hear me? Okay. Yeah, can you just mention, discuss maybe some of the costs associated with ECMO in regards to, like, what's the cost of a device, what's the cost of staffing? And then I guess a related question would be, I guess what Dr. Willis just kind of brought up would be, would you foresee EMS agencies such as like FIDNY developing triage systems where patients with like refractory VFib bypass like traditional CAS centers to go to an ECMO capable site?
In a response to the second part of your question, we kind of just discussed that having specialized centers would be preferred. Just like a stroke center will bypass another hospital, or a trauma center will bypass another hospital that's not certified in either one of those, I would go on to the hospital because outcomes have shown to be better. And I would expect the same. If you can provide good quality CPR, an extra 5 or 10 minutes or whatever it takes to get to an ECPR center would probably make a big difference in outcome. In reply to your first question about the cost, I'm going to tell you the cost of the equipment, the cost of the disposables, but then the cost, most of the cost lies in taking care of these patients after they're on ECMO, because it's an increase in nursing resources, increase in lab, blood utilization, and so forth. So an ECMO circuit, the disposable that contains the pump and the oxygenator and so forth, varies in cost depending on what type of system you have. It can be anywhere from $3,000 up to $14,000 or $15,000. So that's generally a one-time cost for the patient. Compare that to an Impella, which costs probably up to $25,000 or perhaps even more. It's looking to be very cost-effective, and recommendations from the European Society recommend for short-term support that ECMO is preferred over things like ventricular support devices, or even balloon pumps. It's much more highly effective. It supports gas exchange. It gets complete support. Impellas generally provide only partial support. So ECMO has a role in cardiogenic shock. That's very clear and now part of guidelines. But it's the ECPR that we're struggling with now. So the disposable cost I mentioned, the machines vary in as well, from around $25,000 on up to $100,000, and depending on what type you get. Again, the cost down the road is nursing care. So we used to have 2 nurses, or a nurse and a therapist, that were trained to take care of these patients. We've switched our model now with experience to where we only have one-on-one nursing. So that nurse that takes care of that patient is ECMO trained, he or she provides all of the care of that patient. There are higher volume centers that are now spreading out their ECMO-trained nurses or therapists to take care of multiple circuits, and then have individual nurses to take care of all the other needs of the patient. But it's that increase in nursing costs and lab and blood, as I said, that probably represents the most of the cost. But the newer systems, I have a picture of one. The newer systems that are coming out, there's one on the market and others are being developed, are self-contained, small, portable, battery-powered, and have about a 1 foot square footprint. They might weigh 15 or 20 pounds, and they're all self-contained. And those are the ones that are expensive, obviously, and the circuits that they use tend to be expensive as well. Those are the ones that are on the order of $12,000. But if you look at other mechanical support devices, it's actually pretty cheap compared to LVADs and Impellas and other things that are out there on the market. Okay.
I already mentioned that thrombosis was a complication. How often are you seeing that occur in
Well, the thrombosis, these patients are anticoagulated, usually. So the risk of thrombosis is not terribly high. And usually it's thrombosis that's present before we even start. So thrombosis of the circuit happens. It's not that common. Your circuits will usually last for up to several weeks at a time. But after a period of time, the potential for that circuit clotting. So we know how to identify and troubleshoot those circuits and determine when a circuit has to be changed. Clotting in the patient, again, because they're anticoagulated, is not that common. Since we're doing percutaneous cannulation, we leave room around the vessel for flow to take place. So venous congestion is pretty rare. And arterial congestion is the one we have to worry about. Arterial ischemia, limb ischemia. If the vessel, if the cannula is large enough in the femoral artery, it will cause ischemia further down, and that's where the secondary cannula you put in helps to prevent that. So thrombotic complications are just not very common. Bleeding is the much more common complication.
I know there's not a lot of evidence for COVID right now, but what have you seen so far?
The data on COVID is similar to other severe ARDS, H1N1, for example, and trauma and so forth. So in experienced centers, they're seeing typically 50 to 70% survival. But remember, these are the severe end of the spectrum of COVID ARDS. So from a historical perspective, I think that's pretty good.
With those patients, are you traching them earlier?
For the, right, not you're talking about for the respiratory failure patients, for example?
These other patients.
Yeah. Yeah, we'll either extubate them or do a trach if they're on ECMO.
All right, and thank you for doing
Okay.
the
Okay.